Thank you. Good morning, everyone. The meeting with the Assembly Committee on Ways and Means and the Senate Committee on Finance, Subcommittee on Human Services will now come to order. Will the Secretary please call the roll?
Okay, starting roll call. Senator Cannizzaro,
Here.
Senator Dondero Loop, Senator Hammond,
Here.
Senator Kiekefer,
Here.
Senator Ratty,
Here.
Assemblywoman Benitez Thompson,
Here.
Assemblywoman Carlton,
Here.
Assemblyman Frierson,
Here.
Assemblyman Roberts,
Here.
Assemblywoman Titus,
Here.
Assemblywoman Tolles,
Here.
Assemblyman Watts,
Here.
and Chair Monroe Moreno.
I am here. Will you please mark Senator Dondero Loop as present as soon as she arrives?
Okay.
I am here, and I apologize. I had a little tech difficulty today. Thank you.
No need to apologize. We're happy that you're here. It seems IT technical issues has been the wake-up call this morning, so no need to apologize. I'm happy that you're all here, and I'd like to welcome you to our first meeting for this legislative session. We will have public comment at the end of our meeting, so if there's anyone in the public that's joining us, please stay with us until the end to share your comments with us. And I'd like to welcome to our committee today Director Whitley with the Department of Health and Human Services. And we will get started with the first item on our agenda, which will be the administration. And members, that's the first item on your agenda. So Dr. Whitley, are you in the waiting room to join us?
Hi, this is Richard Whitley. Can you hear me?
We can hear you. Good morning. And
Good morning.
Subcommittee.
Thank you. For the record, my name is Richard Whitley, and I serve as the director for the Department of Health and Human Services. And in accordance with the agenda, I did provide a PowerPoint on our major decision units. And if it's okay, I would present each budget and then pause for questions.
That will be fine.
Great, thanks. So just starting on our presentation on page 6, the first budget account is the Director's Office Administrative Account 3150. Turning to page 7, the Director's Office Administration Account is cost allocated to the programs managed within the office and also through statewide cost allocation plan. Decision Unit E900 transfers the Office of Minority Health from the Office of Consumer Health budget account to the Director's Office admin budget account. The Office of Consumer Health account budget is proposed to transfer to Aging and Disability, but the Office of Minority Health should remain in the Director's Office pursuant to AB 141 in the 2017 legislative session. The Office of Minority Health is currently managed in the Director's Office, and this change will maintain the program within the Director's Office. I'd be happy to answer questions on budget account 3150.
Thank you. Members, do you have any questions for Director Whitley on this budget?
Sure.
And if you will unmute and just state your name for the record, because our secretary may not be able to see you all.
Yeah. This is Senator Kiekefer.
Thank you. Senator Kiekefer, go ahead.
Thank you, Madam Chair. And this sort of relates to a lot of the moving pieces that are happening, especially with the movement of with GovCha. Is there a reason specifically that that this program you want to keep in the director's office while a lot of the other ones are pushing over to ADSD?
Sure. For the record, Richard Whitley, I think that the Office of Minority Health does not have the level of capacity that I would be comfortable with embedding it in a division. It really, it basically is a one-person operation with Tina Deutsch as the manager of that program. Unlike the other programs that serve consumers on a continuum from information to advocacy to intervention with the ombudsman, I think those programs are more developed, and really during this past year in the pandemic, we've really had the opportunity to operationalize and see the benefits. That's really why I'm bringing this forward. Is, it's not a concept or a theory that hasn't been exercised. The consumer side, the programs are developed and actually deliver direct services, where the Office of Minority Health is really, it doesn't deliver as an office of direct service. It really is a facilitator of and an insurer of services being provided and addressing disparities amongst populations. So I do think that it should stay in my office, and that we should continue to develop it and benefit from one of my other initiatives, the data analytics.
Appreciate that. Thank you, Madam Chair. Thank you, Director Wood.
Thank you. Are there any other questions?
Madam Chair, if I might? Woman Titus?
Yes. Thank you. Go
Great,
ahead.
thank you. So, Director, again, just some clarification. When we have talked about the importance of recognizing the lack of minority health accessibility, and some of our statistics in our state of Nevada show that we are, again, 50th in lots of things. And this is one where we have, we've recognized, we even passed a resolution that being a minority is actually a crisis in this state. And I wonder how, I'm just not clear on why moving this will actually help. You said that this isn't really being properly developed, and that what do you see as the really advantage of this? You just mentioned that it's a one-person office right now, pretty much, and they're really just kind of an overview. So is the office not actually helping with some programs, suggesting stuff? What has the office currently done? Do we have anything where, what have they accomplished by being in existence? I know our intentions were honorable, but what has it done, regardless of who's directing it? So what's been the accomplishments of it, and what are you trying to then, improve on? And so I'm just unclear about that.
Sure. For the record, Richard Whitley, let me just start by saying that actually the budget movement is really not of the Office of Minority Health. The action that's taken here is to really leave it in the director's office. The action being taken, or the movement, is the Office of Consumer Assistance. Currently, they're in the same budget. And so the movement is really to move the Office of Consumer Health, which then leaves the Office of Minority Health as a standalone. So that mechanics is really maybe not clearly stated as it could be in the budget review that we've provided. But it really is no change to the Office of Minority Health, but retaining it in the director's office. I would say in follow-up to your question on the accomplishments have been a coalition of providers. I mean, as you know, we have a lot of categorical programs. When we look to see, like, are we adequately serving populations that may be underserved? without pulling those out and actually addressing that with agencies, whether that be social services or healthcare services or screening for health conditions that could be intervened with early. The Office of Minority Health really has done a remarkable job highlighting those areas using data. Again, I think that some of the changes I'm proposing in this budget with centralizing data analytics will further help that. So I'm not suggesting that there's inadequacy in terms of what the office is doing. I think they need to continue to work. I think they will benefit from the integration of data analytics so that we can simply, I mean, we're doing it right now with immunizations, with vaccine. Are there populations? We know what the race and ethnicity is of our state. We know it at a community level. We know it, frankly, at a neighborhood level. And so when we look at service provisions that we're trying to, in the case of vaccine, are we actually providing those services to the level that the population represents? And the Office of Minority Health, I think it's a wonderful example of sometimes the change is just through the convening of the stakeholders, the community providers, and sharing the information. And Tina's done a wonderful job bringing those folks together in a coalition in partnership with community nonprofits. I'm happy to provide actually a more detailed summary of those accomplishments. We have an annual report that she produces on all of the accomplishments. So I'd be happy to share that with you.
Great, thank you, Director Whitley, because during the 32nd special session, and SCR1 was urging certain actions to address a public health crisis caused by systemic racism and greatly magnified by the COVID-19 pandemic in Nevada. And I just want to make sure that we're making wise decisions to fulfill what we as unanimously passed was an issue in our state. And I appreciate that you're following through with this. And I just wanted to make sure, especially with Black History Month and some of these things that we're addressing on a daily basis, that we're actually making some changes here to achieve those goals. So very much appreciate you following through with that. Thank you. Thank you, Madam Chair.
Thank you. And I believe Vice Chair Benitez Thompson has a question.
Thanks. I appreciate that. Thank you for being here, Mr. Whitley, and thank you to the staff you have in the room as well. I had one question. I know this position is just one FTE, one full-time employee. I was wondering if any federal dollars through any of the different CARES appropriations that came down federally ended up landing to help this specific position. And I imagine that the answer will be kind of perhaps I'm asking like a direct allocation of grants for this office and this purpose, or indirect.
Hi, good morning. This is Beth Handler. I'm one of the deputies in the director's office, and it's my pleasure to be able to speak to you this morning. Tina Dortch, my colleague, and I have been working with the CARES funds, and we've been privileged to be able to acquire 2 contractors, one through the CDC Foundation that's working with the Office of Minority Health and Equity, and the other through coronavirus relief funds that is also working with that office. Both of these are assigned to COVID-specific activities, but it also bolsters the capacity for the office on some other elements that tie into our overall landscape of minority health and equity improvement.
And I hate to tell you this, but we could barely hear what you were saying. Is there any way you can come closer to the mic and identify yourself and say that again? Because we could barely hear what you were saying. I apologize.
And I appreciate that, Chair. And sorry to make you folks move around. I was leaning in really close because I didn't want to have to ask Mr. Whitley to move. I appreciate you coming closer. Thank you for that.
Good morning, Beth Handler, Deputy Director in the Director's Office at DHHS. And at least we know now that you need us to come up and so you can hear us. So I presume you can hear me now. It's okay. Okay, so the Office of Minority Health has been able to access some of the CARES funding. We've got two contractors through that opportunity. One is through the CDC Foundation, Center for Disease Control and Prevention Foundation. It's an NGO. They've assigned a contractor to the office through our application. And we also have a contractor through the Coronavirus Relief Funds that is also working directly with the office. Both of these contractors are working on COVID-related items, as you know, is in line with the funding source, but it also helps bolster capacity overall and helps us look at some data, some overall scope of what's going on with minority health in the state, as well as working on a toolkit to help with cultural competency, not just with COVID-19, but that will expand out into some other opportunities in healthcare.
Are there any other questions from members? Seeing
Yes,
that,
Madam Chair. I'm sorry, Assemblywoman Carlton, Madam Chair.
yes, Assemblywoman Carlton, go ahead.
Thank you very much. And it might be a two-part question, so if I need to follow up, I'll be sure and ask you if I can follow up. So, Mr. Whitley, I think some of the confusion's coming from the way I read the notes. It looked like the Office of Minority Health was moving. But what I hear you telling me is there's a group all together and a section of them are moving. So it reads like Minority Health is moving to the director's office, but basically it's like checkers. It's like a double hop. It's staying there because the rest of them are moving. Do I understand that correctly?
Yes, for the record, Richard Whitley. Correct. They're in the same budget. So a lot of times we have multiple programs that are distinct in one budget, and that is the case here. So it reads like, as you said, like we're moving Office of Minority Health, but we're really moving out the Office of Consumer Health, which then the Office of Minority Health remains. So it does read like there are movements occurring that in actuality don't functionally change anything. The Office of Minority Health remains in the director's office.
And thank you very much, Mr. Whitley. And Madam Chair, if I may follow up briefly.
Yes,
So
go ahead.
I guess the second part of my question is, and we'll probably get to this when we get to that budget, but when I think of the Office of Consumer Health, I don't think of it in aging and disabilities. I don't think the folks who would think about looking for assistance would know to go to aging and disability to look for that category underneath it. So if that's going to be addressed a little bit later on, that's fine. I just wanted to let you know, I'm just, sometimes it's hard, and I've especially noticed it in the last 6 months, for our constituents to navigate state government. They just don't know what rabbit hole to go down to find what they're looking for. So I just want to make sure that we're not moving something and folks won't be able to find it and access the help that they need. So that would be my only concern. But thank you for clarifying that for us. And Madam Chair, thank you for the follow-up.
Thank you, Assemblywoman Carlton. Any other members with a question for Mr. Whitley? Well, seeing none, I do have a comment. I would like to applaud the work that one employee in Minority Health has been doing. In Southern Nevada, she has been an amazing asset to us legislators trying to get information out in the community. There has not been a health town hall that I've tuned into. She has not been there to represent her department and DHHS. I'm not sure how she does it, being that one person, but she has been amazing. So I would just like to say thank you to you and to her for the work that she has been doing in our state.
Thank you. And I completely agree. Tina is phenomenal and will remain in this office as a report to me, and will have my full support as we move forward and make more progress. If there aren't any more questions, I can move on to the next budget.
Thank you. That would be great. We'll move on to budget 3155.
Great. The next budget account is family planning on slide 8, which was created by the 2019 legislature and resides in NRS 442.725, to fund local government entities and nonprofit organizations to provide family planning services to all persons who would otherwise have difficulty obtaining such services because of poverty or lack of insurance or transportation. Slide 9 shows that the funding account is 100% general funded. The decision unit in E680 reduces the family planning program from 3 million per fiscal year to approximately 2.4 million each fiscal year, and that's based on the actual expenditures during the base year. So funding level will, with base year expenditures, is the action here, and I'd be happy to answer any questions on this budget account.
Thank you, Mr. Whitley. I think we'll have a few questions on this budget account. Assemblywoman Benitez Thompson.
Yeah, thank you, Madam Chairwoman. I appreciate that. And so, Mr. Whitley, something that we have been able to do in the past that the department has helped us with in kind of establishing the legislative record to show where these dollars go and which communities are being positively impacted by these dollars. We've kind of been able to get a rundown of where dollars went and what they were being spent on. And I was wondering if that's something that would be able to be provided for staff, just so we get that nice, healthy legislative record of how those dollars are working.
For the record, Richard Whitley, absolutely. I think actually because there are different funding streams in terms of health plans cover or pretend to cover family planning, it's not always easily accessible. These dollars do supplement and they don't subsidize, but they supplement. So I think it would be helpful to have that complete picture, and I'd be happy to provide it.
Any follow-up, Assemblywoman?
Thank you, Madam Chairwoman. No, I just love that information because it's always been helpful to see the communities and what we're buying. And I'm a concrete thinker that way. Thank you. Thank you, Mr. Whitley.
Thank you. I have Assemblywoman Titus.
Thank you, Madam Chair. I appreciate the opportunity. Director Whitley, in your budget, you're reducing it, you're reverting about $680,000 to the general fund, and the excuse or the explanation is that these were unused funds. From a historical perspective, as the Vice Chair asked regarding, how were these funds spent, I'm concerned that that's not an actual picture of what the needs or what the funds could have been used for had we not had this horrendous pandemic where people didn't go to the family planning agencies that they would typically access, because we know across the state folks did not access healthcare, whether it was through the Medicaid or private insurers. We know that there was a lowering of the people seeking care because of the COVID pandemic. And I'm just concerned that by not continuing to fund this budget and previously determined needs, that we're going to leave a hole at the end. And to the point of this is that we know that, again, we have some significant issues, especially regarding some prenatal care, again, congenital syphilis, all of those things that happen because of lack of access to care. And so I'm worried that by not continuing to fund it as was determined the needed funding for that 2020 budget, that folks will not be able to get the needed family planning that they would otherwise have access to.
For the record, Richard Whitley, I mean, this is an outcome of base budgeting. I mean, this is what we expended. I don't think that we have added. I mean, as you'll hear throughout the divisions in my department, that the projections on caseload on service utilization is really tough because we've not been here before. And in terms of what factor does the pandemic play in our service delivery and going forward? But this is what we spent, and the budget was built based on what was expended. during the base year. So I certainly, we will monitor it. This is a program, women's health. We have a whole initiative in our department on prenatal to 3, really focusing on that population to have healthy birth outcomes, supporting family planning like this program does. And so we'll be monitoring it, and I'm happy to provide information should an unmet need or unmet needs be identified or arise. But this is based on the actual expenditures and the base budgeting.
Follow up, Madam Chair?
Go ahead.
Thank you. So to that end, again, as our vice chair had asked, a breakdown of where these funds do go, because I think some of these family planning, some of this family planning monies go throughout the state, whether it's the rural health clinics for some family planning out there, both our urban centers across the state. And so a breakdown would be nice to see where the expenditures really are for these. And as this goes forward, if there's truly a need, I appreciate that you would bring that back. So thank you for all you're doing, and thank you for the question, Madam Chair.
Thank you. Assemblywoman Carlton.
Thank you very much, Madam Chair. And following along Dr. Titus's line of questioning, she did ask a couple that I was interested in, but just I know when we first started this last session, there was a lot of debate at where the funding level needed to be. And it was pretty vibrant debate on where we wanted to go. And we, Senator Woodhouse and I and the governor's office, in the final resolution that we had was we would rather overfund a little bit just to make sure the resources were there because we didn't know and we knew how important this program was, and then be able to adjust when we came back. So I want to thank the director for doing the work, doing the analytics on this. When you do start something new, that base year is key, and we'll work from that base year forward. And if we need to make adjustments in the future, we can. But that's basically the formula that we use when we start a new program. So thank you very much, Director Whitley, for all your hard work on this.
Thank you, Assemblywoman Carlton. I believe I have Assemblywoman Tolles next.
Yes, thank you so much. And thanks for that history and explanation of how we got to these reductions. I too shared a lot of the questions that have already been asked, but a new one popped up for me as I was listening to this. As we've adjusted through COVID, oftentimes that it's brought about some great opportunities to innovate the way that we provide access to services and healthcare and so forth. And it comes to mind that we've seen some real success with mobile units, for example, the mobile mammogram van, and some other opportunities to really go into communities that have, and particularly in light of COVID, may need services to come to them. I'm just curious, was that ever anything that was explored or pursued, ways to, instead of doing outreach to bring people into the traditional clinic settings, has there been opportunities through mobile units and what have you to bring it into those communities in ways that would still help to protect safety but accomplish the goals that we're seeking?
For the record, Richard Whitley, I'm not familiar with any direct parallel to the MAMA van that is operated by Nevada Health Centers doing outreach for mobile mammography. But I do know that as Assemblywoman Titus mentioned, rural health clinics, federally qualified health centers, certified behavioral health clinics do utilize family planning. Sometimes for in the area of women's health, it may be family planning that is the touch point to primary care. And it is a way of getting perhaps someone that may have high risk in other health areas into healthcare. And so outreach does occur. And I really want to give credit to what that actually is. So I'm happy to provide the detailed report of as Assemblywoman Benitez Thompson asked, for the actual services that were provided. But directly to your question, it has not purchased a similar sort of service model like mammography that Nevada Health Centers operates in the state. But it is a good question. Not to get off track, but that mobility from telehealth to mobile services, we're seeing across the board, even in food deserts with mobile grocery stores. So it's a good question, and we'll continue to explore the opportunities, and maybe there'll be federal funding as well that we can tap into. But I appreciate the question and the service model indication that you offered.
Thank you, Madam Chair. Quick follow-up.
Go ahead.
Thank you. If there is data on what the cost is for the Mammovan, for example, just by way of comparison, that I'd be interested to see that. Thank you.
Sure.
Thank you. Senator Ratty?
Thank you, Madam Chair. My main question was the rationale behind the 20% reduction, and I think we've covered that ground, but I did have a follow-up question. I'm going to be super cautious about how I'm phrasing this question, because I do not want to leave the impression that this would be around diverting funding to another important priority or anything along those lines. But what I'm curious about, I remember from the legislation last session, and it was also a robust debate, at least on the Senate side, that we included vaccination as one of the allowable expenses within this category. And I suspect as we get to the July timeframe, as we're moving through the COVID-19 vaccination process, that hopefully we'll be looking at that 18 to 64-year-old healthy population, and we'll be doing pretty significant work to try to bring in a lot of folks who generally haven't had access to healthcare, that this program is particularly aligned with, and really the family planning might be the carrot that brings people in, but that this would then also be, those same providers would be able to be doing vaccinations. So I'm just curious if you believe that the way that it's set up allows for that, and that particularly in this moment in time and the work that needs to be done this year, if that would be a consideration.
For the record, Richard Whitley, I mean, an excellent point. We're utilizing all of our programs as you described. That may be the touch point or entry point to a population or a demographic that maybe only seeks a single service. So we are looking at that, and family planning definitely as it relates to women's health, and to a population that maybe only seek family planning for their health care. We definitely are looking at how best to utilize that for outreach to populations for vaccination.
Thank you.
Thank you. Members, any more questions? Any other questions?
Would you like me to continue?
Well, I'm not seeing any other members with any other questions, but I just want to make sure we get something on the record. Do you expect to expend, and if you answered this earlier, please forgive me if I missed it. Do you expect to expend the total $3 million for FY 2021 that was authorized and approved by the 2019 legislature?
For the record, Richard Whitley, we've allocated the funding, but it depends on if the contracted agencies actually are able to deliver all the services, which is the case with all of our contracted services. We allocate it and monitor it, but at the end, if the services weren't delivered, they're not reimbursed for not delivering the service. So it is the intention to expend the funds appropriately for the services. We'll continue to monitor it, and we also make adjustments along the way if an agency, in these times right now, a lot of the nonprofits are really struggling. And so we have to hold to the integrity of the funding and the purpose of the funding. And so we monitor for that. But if we have an agency who isn't able to provide it, we don't stop there. We do seek other nonprofits or agencies in the community that could provide the service. So yes, the plan is to expend the funds.
Thank you. Members, before moving on to 3195, are there any other questions on this budget? Okay, seeing none, we will close the discussion on 3155, and Director Whitley, if you'll go on to 3195.
Great. Moving on to slide 10 in my presentation, budget account 3195. This includes the grants management unit, and it administers, monitors, and audits the following programs: the Title 20 Services Block Grant, the Community Services Block Grant, Healthy Nevada grants, which comes from tobacco settlement funds, and Nevada 211. On slide 11, it shows the proposed changes in this budget. This budget is cost allocated based on time and effort. And in decision unit E805, it reclassifies an auditor position to a management analyst. And throughout the Department of Health and Human Services, there are management analyst 2 positions that support fiscal oversight for programs. And the duties of this position expand beyond the classification of an auditor, as they are responsible for tracking the federal awards and tracking Healthy Nevada funds, as well as performing audits on subrecipients. The E904 transfers the 211 program, which includes 1 part-time social service specialist, to the Division of Aging and Disability. Transferring the 211 to the Office of Consumer Health Assistance to Aging and Disability complements an array of consumer supports that I've talked about previously. Moving on then to slide 12. This shows the breakdown of the Healthy Nevada funds. The Healthy Nevada revenues have remained steady over the last 10 years. It's at approximately $24 million a year. We're obligating approximately $3 million less this biennium due to the budget sweeps that of $16.8 million during the special session. The balance forward at the end of the biennium is projected to be approximately $17 million. On average, approximately 92% of the legislatively approved budget is actually spent. So if this continues, the balance forward at the end of the biennium will be approximately 20 million. And we did, our chief financial officer did do a cash flow analysis, and it shows that we'll be good this biennium, but depending on year-end reductions may need to be made in the future. Turning to slide 13, this shows how the grants management advisory committee has allocated the funding. The chart shows the categories where the tobacco funds are proposed to be spent and the differences from last session. The main areas with changes are in senior RX and senior independent living. The reduced funding for senior RX reflects the changes really that occurred at a federal level in Medicare Part D program and eliminated the need for a pharmacy subsidy program. Continued funding will be maintained for Medicare Part D premium subsidy. The funds requested to be moved to independent living programs to address broader services for the same population. And then I would also highlight that Southern Nevada and Northern Nevada mobile outreach programs. This increase is due to replacing general funds with Healthy Nevada funds, which changed during the special session. And the final one is autism. We replaced Healthy Nevada funds with TANF funding. No change in the service, but a change in funding. Turning to page 14, this slide shows the allocation of the Title 20 funding. We are projected to have a slight increase in the total funding available, and the amount allocated for administrative costs was revised to more accurately reflect the operating expenditures, freeing up additional funds for services. A notice of grant award was released in November, and allocations were based on the requests received. Portions of the non-state welfare category is used to ensure solicited services are available statewide, as well as direct subgrants to Washoe and Clark County for their child welfare programs. And that would conclude my presentation on budget account 3195, and I'd be happy to answer questions.
Thank you, Director Whitley. I know there's a few questions on this budget. We'll start with Assemblywoman Carlton.
Thank you very much, Madam Chair. I appreciate that. And this is one of those budgets where there's so many moving parts. So I just want to make sure I get a couple top issues done, and then I do have a couple specific questions. So, and I asked this in the pre-session hearing, so I'm sorry if I'm repeating myself, but I think it's important to be on the record. The changes to 211 are strictly administrative. There'll be no other changes as far as where it's located, who's working for it, how it's funded, its mission. This is merely a very top level change that's going to be happening to 211.
For the record, Richard Whitley, you are correct.
Thank you, Mr. Whitley. And with the tobacco settlement funds, if I could ask a couple quick questions, Madam Chair, and then I'm sure Senator Keycover is going to be right behind me, so I'll just tee him up for him. So with the incubator project that we started, that was for the new FQHCs. Can you tell me where we are with that?
Do you want to keep going?
Good morning again, Beth Handler, Deputy Director, DHHS. And with the incubator project, we actually just released a new notice of funding opportunity. This notice of funding opportunity is for the federally qualified health centers incubator project applications to apply. The primary topics this time are primary care and telehealth, and that NOFO, has currently been released.
Okay, and what has already been accomplished with the money that we set aside last time?
Sorry, I apologize.
No, that's okay. It's that I didn't make it clear.
I apologize. I was looking forward, and you want a report out on what we did with the money previously, and that, so that is my area. So the telehealth that was supported in previously focused on school-based health, and Clark County School District and several rural school districts, including Carson City, did apply and were awarded. And we have seen, certainly impacted by the pandemic, but we did see enhanced services being offered with partnership with the school health nurses, which has been really a system change when it relates to schools and school health and the role of the school health nurse. So they've been facilitators on the receiving side with the consumer, and Nevada Health Centers was the large provider in our state for those services, partnering with Clark County School District. I can get you a list of the school districts that they worked with, but really great outcomes at helping kids stay in school, working parents who maybe would have to take off to have a doctor's appointment. And then again, just like I mentioned on the family planning, sometimes a touch point to primary care and that relationship with the federally qualified health center to get not only the student, but the family access to primary care. So it's been a wonderful venture in partnerships and bringing folks together. Telehealth is really, I think, as we've even seen in the pandemic, improved service access, but definitely in schools. And when kids start going back to school, we want to pick that up again and continue to monitor the outcomes. And really, it's too rich not to expand or to encourage more schools to do.
And thank you very much, Director Whitley. It's so nice to hear good news that something we worked on last session to make sure got on the ground for folks is doing what we hoped it would do, and hopefully we'll start up again. And Madam Chair, if I may ask just one more question, and it's not that any of these are in any special order, it's just I know other members have special interest in some of these other categories, so I won't touch those. But one of my special interests is hunger prevention. We have seen, in the last 9 months, this has become a big issue. So if you could expand on the dollars that'll be going towards hunger prevention, because we do notice these dollars under wellness are going up. So if you could expand on that.
Sure. For the record, Richard Whitley, I mean, I think you make a great point on food and housing are probably the two determinants of health that my office gets the most calls about. The categorical nature of the USDA funded programs, from commodities that provide resources to food banks and to food pantries, to SNAP, to WIC, to school lunch programs. That is a fragmented system that maybe a family could qualify in multiple areas. And I would also add Meals on Wheels for seniors. Those contribute towards a family's access to food. The Fund for Healthy Nevada has more flexibility to support the gaps that those, as you know, many of those programs have limitations or even the access point. And so I'd be happy to provide a more detailed, and probably should have thought of that with food security and just the challenges that people are having right now. And it's also the challenge of navigating. We're seeing more and more people who have never had to rely on food pantries or really assistance. And so helping them without stigma to navigate the system has really been an effort, but I'd be happy to provide. I think actually it'd be nice for me to provide in context of the food programs we have that are categorical, how Fund for Healthy Nevada complements those. And I'd be happy to provide that.
And thank you very much, Madam Chair, for the latitude of all the questions. I know there's a lot of other people who have questions, so I'll sit back and listen now. Thank you very much.
Thank you, Assemblywoman Carlton. We have Senator Kekeffer next.
Thank you, Madam Chair. I appreciate it. And thank you, Director Whitley. And you touched on a couple of things. I had a question about the timing. I know we receive these lump sum payments in April, and our staff indicates that usually we fund the next year's programs with that allotment, but now we're going to be funding current years, so the current fiscal year with the April payment. You had talked a little bit about cash flow. So are ultimately we paying for a fiscal year's programs with our carry forward and our ongoing balance in this account, or is it just going to be sort of blended?
For the record, Richard Whitley, and unfortunately, the way we're set up here, I'm not sitting next to Stacy, the deputy over finance. So you'll have to get my attention if I get this wrong. But we rely on the startup each year on reserves, and historically we've spent about 90% of the Fund for Healthy Nevada, and so the concern is if those reserves get too low, our ability to continue services at the same level could be impacted. The analysis that our financial officer did, which does look sound, and I'm confident in his work, would indicate that we're okay for the biennium, but should things change going forward, we may have to reduce the award amounts, to operate within the budget. But we have, in many of our programs, we do rely on reserves for the startup. When
you say things could change going forward, what kind of things would need to change? I mean, we know how much we're granting to agencies and we know how much we're going to receive, right? Or is this if there's a decline in our allotment of master settlement agreement funds?
I mean, those are variables, but also, we saw back in 2008 when we struggled with the economy, nonprofits and organizations really struggled. We lost a lot of them. We're looking at the reserve balance of, like I said, about 90%. But if and that is a variable that we've considered in terms of what would be available to start up each year. So
I think that's fine. I don't think we need to call in. I appreciate that. I see that the decision was made as well to continue funding most programs with these funds rather than switching them back to a general fund source. I have some concerns about that in terms of stability, but was there any discussion about moving this back to, or moving those most funds back to a general fund appropriation?
For the record, Richard Willie, yes, we had discussions about every funding source we had that had flexibility, faced with a challenge of having to go through an exercise of reducing general fund spend. We simply are trying to maximize available funding in the appropriate categories for this time. As we go forward, looking at how to stabilize those fundings, of course we should do that, and I would commit that our agency does that continually if we're able to get federal funding for a program. But we did look at every opportunity and do hold to the stabilization of essential services and not reliant on funding that may change in the amount and impact services. But I guess I don't know how to say this fiscally, but we are getting through the moment in some cases with just with funding that we have and the flexibility that we have within the funding stream.
Yeah, I appreciate that. And finally, Madam Chair, on Title 20, it's been a while since I've looked at it. Is that a flat amount? Is that formulaic, or does our allocation change? I was for some reason under the impression that it's basically been the same since the 80s or something.
It is a formula from the feds, which it would take a congressional act to change the amount.
Okay, so that's static.
Yes.
All right. Okay, that's all. Thank you very much, Madam Chair. I appreciate it. Thank you, Director.
Thank you, Senator Keycapper. I believe Assemblyman Roberts has a question.
Thank you, Madam Chair, for the promotion. And yes, I have a question, Director Whitley. It kind of goes into Senator Keycapper's question regarding most funding. He asked the portion I did about sustainability. And my question is, I see the dollar amount has been increased. Last budget cycle, they ran out of funds in Southern Nevada for that program, and you increased it, which I'm really glad to see. It's a worthwhile program. My question is, do you think that is enough to sustain both of those programs in Northern and Southern Nevada during this next budget cycle?
For the record, Richard Whitley, I think it probably doesn't get talked about as much with the pandemic and the focus on the virus, but we have seen an increase in crisis in the area of behavioral health, both with substance abuse as well as behavioral health crisis, and so it's hard to tell what the need's going to be. We try to be responsive. There are some opportunities within crisis services to also maximize reimbursement, and so we have a team that works on this with our local partners on how to maximize all of the resources that are available, the federal funding, reimbursement, as well as this funding. So we continue to monitor. I think on all these services, you probably make a good point in your question. I think all of these services, reporting out what we're seeing. They may not be the highlight right now, but definitely at a community level, first responders and folks who have to respond to this crisis, they are experiencing it. And as people have been asked to isolate, we really don't have enough data to predict what the need will be, but we are monitoring it. And I would say that we have good relationship with our local partners who are responding and have the benefit of this resource.
Well, thank you. Thank you for that answer. And it's an important program. If we continue to fund it, it certainly, helps police officers and first responders out there in the streets. So thank you. I appreciate it. Thank you, Madam Chair.
Thank you. I know we have a few more people in line with questions. Have Assemblywoman Tolles next.
Thank you so much, Madam Chair. And I'm just curious, looking through, just going back to the original purpose of the tobacco settlement funds and to be utilized to help with, education and reducing dependency on nicotine and making the public aware of, some of the issues involved with cigarette use, having a memory seared into my brain of losing my grandmother to emphysema at a young age. I just wonder, now that we're seeing a crisis among youth of using e-cigarettes and vaping products and so forth, is there any of the contribution to these settlement funds drawn from e-cigarettes and from vaping products? Does that help contribute to these funds? And then I see that we have, depending on the year, between 1 million and 2 million dedicated to cessation programs. Could you just talk me through a little bit more how those are being utilized and if they also do incorporate vaping? Thanks.
Great. For the record, Richard Whitley. So quite a few questions packed in there, and I'll start with the service side. Tobacco cessation under the Affordable Care Act is an essential service that is covered. But as you know, and we probably have the most research in the area of tobacco use, based on change theory, and that brochures and information, knowledge doesn't change behavior. And so even having a service available, if people don't access it. And so helping to bridge and promote access to tobacco cessation, which is covered by all commercial health plans as well as state Medicaid. It is promoted, and some of the dollars that are used out of the Fund for Healthy Nevada do go to promoting access and education. But to be effective, the targeted strategies have to meet the people where they're at. They may be knowledgeable, but not ready. They may be ready, but not know where to access. And so we probably have the most research in terms of changing behavior in the area of tobacco addiction. And so these funds are used to support in a supplemental way to the funding sources that also go to provide tobacco cessation, as well as to fill gaps when somebody maybe is uninsured or underinsured. In terms of vaping, it is. I think we probably could do more in that area. We still have high rates of tobacco use, traditional tobacco use among youth. We've seen improvements in our state, but we still have high rates, and so the work isn't complete. And I think the vaping funds that were that were supported last session really was a starting point in that area. I think the strategies are even different. The counter marketing, it's a relatively new area for us to support. in terms of vaping, but I think there's lessons learned from traditional tobacco use. But these dollars out of Fund for Healthy Nevada that come from the settlement are used in the area of traditional tobacco use prevention and intervention.
Thank you, Madam Chair. Just a clarifying follow-up question, please.
Go ahead.
Thank you. So I think I forgive me if I missed the answer, but I know that the funds are a percentage of sales of cigarettes to fund the tobacco settlement, if I understand it correctly. So if a vaping product or an e-cigarette is purchased, does that also contribute to the fund, or is that not a part of these settlement funds?
That's not a part of these settlement funds.
Okay, thank you.
Thank you, Assemblywoman Tolles. I have Assemblywoman Benitez Thompson next.
Thank you so much, Madam Chair. So my question is on the shift from these dollars for the autism, the ATAP program, and then using instead TANF dollars. So I know that whenever we talk about shifting services or shifting money in, that can get complicated at times. And so could you just talk on the record that we don't anticipate any type of program interruption with the shift of these dollars? I know that I was one who kind of automatically thought, oh, well, if it's TANF dollars, then we've got to have recipients who are TANF qualified, and we might have kind of a new set of paperwork for families to use. But that's not correct. So I was hoping you could put that talk about that for the legislative record, just so we could start getting accurate, information out to families about what this shift means.
Sure. For the record, Richard Whitley, TANF, or Temporary Assistance for Needy Families, is a funding stream that has broad use categories. In terms of the direct assistance to families, it's probably our lowest poverty level program. It's 100%, basically 100% of poverty to be eligible. If you look at our largest caseloads, Medicaid, SNAP, the Supplemental Nutrition Assistance Program, and TANF, we've seen increases in the utilization of Medicaid or the enrollment into Medicaid and the SNAP program, but we've actually seen a decrease. And I should have given more thought how to say this, but people who are truly and were before the pandemic living in poverty, we've not seen those numbers increase with that at or below 100% of poverty in the same way that we've seen people who've lost their jobs and now are eligible for SNAP, which is around 200% of poverty, or Medicaid, 138% of poverty. So we haven't seen the caseload growth. In fact, the caseload for TANF is below what was projected during the last legislative session. We also do carry reserves in those programs. And so it's an allowable expense. Again, is it stabilized funding? Are there other uses for it? The answer is no. It may not be as stable as state general fund, but state general fund isn't stable right now. So again, we're getting through the moment of trying to provide the essential services with funding streams that are appropriate, but we are not reducing any temporary assistance to needy families.
Thank you so much. And just as a quick follow-up, we're not going to be asking families to have to qualify for TANF. It's a separate set of qualification criteria for ATAP. So dollars will go in. So from the consumer side, it will be seamless. They won't see a change. Right?
For the record, Richard Willie, that's correct.
Thank you.
The categories are broad.
Thank you for those questions. I have Speaker Frierson next.
Thank you, Madam Chair. I was referring to slide, I think 14 on, trying to pull it back up. the non-state child welfare. And I really have two questions there. The first was how that is distributed, and is it based at all on population? And then the second question is, it looks like there's an increase of over $1 million, and what the plan is with respect to the extra dollars in that particular category.
I have to phone a friend, so I am going to have Beth Handler come up and respond. Oh, you are. Well, she would have to phone a friend too. I apologize for that. I don't have it readily available to me, and I don't want to get it wrong in terms of what the how it's allocated to the counties, if that's based on population or on need or history, and then the additional dollars, the allocation of where they're going and how that decision was made. I'll provide that.
Thank you, Director.
Thank you, Speaker. I believe Senator Dondero Luke is next with a question.
Good morning. Good morning. Thank you so much. I have a couple questions. One is, could you please confirm or reiterate what you said about the autism funding?
Sure. For the record, Richard Whitley. What we're doing, we're not changing the service delivery level or model. We're changing the funding source from Fund for Healthy Nevada to the TANF, the Temporary Assistance for Needy Families funding, an allowable category in that federal funding for those services, and with the intention of not to have impact on the families receiving the services.
And why would that benefit your division?
For the record, Richard Whitley, as you know, with autism services, there are multiple funding streams that are the support for those services, from healthcare coverage to direct assistance. And so this really is just allowing funding to continue the level of support, but where we have flexibility with the funding stream, the federal funding stream to support it, to utilize that so that we still can utilize, for example, the Fund for Healthy Nevada in other areas that are, equally important, hard to prioritize, but it's really a matter of where the flexibility exists with limited general fund, how to maintain a service level during these times, and not do harm. And so the intent here and what guided us was to not reduce services or limit them, but where we had the flexibility, which was in TANF, in the TANF reserves, was to utilize it and not do reduction.
So, and forgive me because I have not sat on finance before, but I guess I'm just a little bit, it feels like it changed over to TANF, but I'm not sure why. I guess I'm not sure understanding why it needed to do that. Was there some efficiency that made it better? Was there, if the money is not going to change, what was the sole purpose of moving that?
I think that, for the record, Richard Whitley, it is an important question. Some funding streams have more flexibility. I think when I presented on mobile outreach, for example, and supporting the activities in mobile outreach, the Fund for Healthy Nevada can support that, but TANF funds can't support it. That's not an appropriate expenditure for TANF, but autism services are an appropriate, focusing on children and improving their outcomes is an allowable expenditure. We had reserves in TANF and available funding. So the goal was to not reduce the services. So it was to change the funding support, but not change the service. So that we wouldn't have to reduce other programs.
So just to confirm, there is no money difference. It's just a different entity that is distributing that funding.
Correct. For the record, Richard Whitley, it's changing the funding, one of the funding source from Fund for Healthy Nevada to temporary assistance for needy families.
Okay. I will, Chair, I will stop there. I have another question, but I'll get back in the queue if somebody else doesn't ask it. Thank you very much.
Thank you, Senator. And we have Senator Hammond up next.
Thank you, Madam Chair. I just have a couple of questions, and basically it's for general knowledge because this is my first time on the committee and the first time dealing with the tobacco settlement. And also, of course, talking about stability. I think some of my colleagues have talked about stability of that account. So the question I have is, I understand that the tobacco settlement money coming in is based on the percentage of sales of the tobacco products, excluding vaping or anything of that nature. Is there even though it's based on a percentage, is there a timeline on that? Is there a certain number of years that settlement is in place? It ends after 10, 15 years? That's my first question right there. And then secondly, I'd like to know, has that money declined steadily over the years, or is it actually increasing? I noticed that you said that even though there's a lot of knowledge out there for smokers and knowledge is increasing and there's accessibility, it seems to not actually put a damper on their desire to secede from smoking. But I just wanted to know if that has decreased at all, and can we anticipate a decrease in the future based on the data that we have from a few years past?
For the record, Richard Whitley. So the Tobacco Master Service Agreement that supports the Fund for Healthy Nevada is a negotiated agreement, and I'll have to follow up. I don't believe there is an end date in it, but I will confirm that in a follow-up. So it is a master service agreement, so it does have detail. I'll provide that for you. In terms of the dollar amount, the funds have not gone down over the years. Again, it's not a. I mean, I feel like I'm talking out of both sides of my mouth here. We want people to quit smoking, and we're supporting it, but we get the revenue from the tobacco use. So it doesn't appear that has reduced over time, and so there's no indication in projecting that it would dramatically go down.
I appreciate that, Madam Chair, and just maybe they can clarify or give me some information later on. If I could just ask this last thing, and that is, can we isolate perhaps the fact that our population has increased, and so therefore that might be a rationale for it not going down, or there's just no way to isolate that information, and so we just see the increase, and that's it.
For the record, Richard Whitley, I mean it is based on tobacco use, and so I can.
That's fair enough.
I can show you the data, but I can't really explain the purchase.
Yeah, that's fair enough. I definitely will dive into it a little bit more, so I appreciate it. Thank you, Madam Chair. And thank you, Director.
Thank you. We have just a few more people with questions. We'll have Assemblywoman Titus, followed by Senator Ratty.
Thank you, Madam Chair, and thanks for all the great questions. And Director Willie, thank you for all your great answers. I want to kind of piggyback on what Senator Hammond's question was, just from historical data and where we're going with this tobacco settlement funds. Just back in the 90s is when this settlement was done. And I actually served as chair of a committee that was formed, a trust fund for that, some of that settlement money. And it was peeled off, and there was a strict statute on what that money was to be used for. And part of that was the Millennial Scholarship. Part of it was this Healthy Nevada Fund. And then there was this trust fund, which was then swept during the Great Recession, which no longer exists. But it was my understanding at the time that there was a hard stop date on when these settlement funds, when the settlement ended. And we've had this conversation worried about the Millennial Scholarship. How will we fund it when these funds are no longer here? So I'm surprised to hear that this is a perpetual fund, because that was not the original impression that I had based on the history of it in the 90s. So maybe it's been changed. And I think we all need to have some, maybe a review of what that's about, and just kind of dust off some of that settlement money, because I have some concerns about that. And clearly you can't answer that, and you're going to get back to us with some information. All of us on this committee will probably be doing some homework on that. A specific question is, however, you mentioned early on in your comments that you're spending 90% of this revenue that you're getting. Is that what I heard you say?
Correct. For the record, Richard Whitley. Correct. When we allocate the funds, the actual expenditures of that allocation is around 90%, which does then add to the reserve that we carry forward.
And that decision to spend 90% is made by whom? Is that anywhere written? Is that something that you've just decided to keep that 10% balance extra, or where did that 90% spend this money and come from? And apparently that doesn't revert back to the general fund based on a conversation we had earlier about family planning. So how does that 90% figure, how did you arrive at that?
So we don't set that. That's based on historical utilization. And just like I think I explained with family planning, you know, we do RFPs, we allocate the full dollar amount, but you know, many nonprofits have intention to provide all the services, but as they implement, they're not able to, and so we don't pay them for things they didn't do, and so this results in unexpended funds. What I'm saying in the 90%, and maybe I could have said this better, is that really is just the average amount that we have seen over time that was actually expended. It's allocated, but it's just not always spent. We monitor it throughout, and you'll see in every program we have with a federal grant that what was awarded, what was allocated, and then what was actually expended. And, you know, depending on the complication of the service, it's not always spent.
Great. All right. Thank you. Thank you, Madam Chair.
Thank you. Senator Reddy?
Thank you, Madam Chair. Great questions, and I just have a couple clarifications I want to get on the record, just because there's some significant interest in some of the public health advocates in these. So on the MOST program, I know folks have talked about that a lot. And I know we went from general fund to what we needed to do in the special session with CARES Act dollars. And so now it looks like it is in the this funding source. First question is 100% of the MOST funding that comes from the state in this funding source, or are there other sources of funding as well that we'll come across as we move through the process?
For the record, Richard Whitley, primarily it is from this funding source. There may be, as I said before, some reimbursements that can occur if the recipient of the outreach is like on Medicaid and the provider does get reimbursement. That's not reliable. That's why it makes having core funding like this, supporting that intervention, so important. But this is the primary funding source. I'll just so that I'm being, completely accurate, I will follow up to make sure that there aren't any other supplemental grants that are touch points to this. None come to mind.
Great, thank you. Then my second question is that Assemblyman Roberts had referred to it as an enhancement and more funding. And I wasn't clear, is it really more funding, or is it really, and this is probably just me as a newbie, Or is it really just an enhancement to this budget category because there's more money in this budget category? So for the folks who get this funding, are they getting more funding in this upcoming biennium, or are they just getting the same amount of funding?
For the record, Richard Whitley, I mean, we are changing the funding source. So I don't, I'll verify again, but we're not enhancing funding. And maybe I could have done a better job with this sort of movement of funding. The service isn't changing, but the funding stream is changing. In this case, I mean, gosh, just looking at the line of questioning across the board, this is probably a good example where a shortage of general funds, rather than cut the service, we moved it to Fund for Healthy Nevada, an allowable expenditure within that negotiated settlement agreement and the uses of those funds. That then took up dollars in Fund for Healthy Nevada, which funded, among other things, autism services. We saw that we had a funding stream with temporary assistance for needy family that could provide that service. So it really is a matter of when we got in a room with our services to do no harm, to see where our flexible funding was. So I probably could have done a better job explaining it isn't a new service, it's new to this funding stream, but it's not additional services.
Great, and I appreciate that. I appreciate the creativity that your team is putting in on making sure that we're maximizing federal funds with anything that qualifies. And then therefore there's a lot of moving around to save programs. So 100% on board with that. I just know that an awful lot of folks are interested in this particular budget. And so I just want to make sure that it's clear on the record that different funding source, same amount of money is going to most.
Correct.
Thank you. And then also on most, now that it is in this particular funding source, will it be a competitive grant program, or will it be allocated the same way that it's been allocated in the past?
The intention would be to allocate it the way that it has been. I mean, it's too disruptive to change the service model.
Great, thank you. Then moving on to vaping, I just also wanted to get this piece on the record. So this fund has, of course, the tobacco settlement dollars that are allocated to tobacco cessation. You had talked about SB 263 and the funding that was allocated in the last session, specifically to target vaping prevention. It was $2.5 million a year, which is, of course, more than the entire tobacco cessation fund that comes out of these funding sources. So, this is no judgment in the decision or anything along those lines, but I do want to get it on the record. So that $2.5 million per year that came out of SB 263 in the last biennium has been treated like a one-shot, is not in the base budget anywhere. And so that funding will go away unless we choose to do something different. Is that correct?
For the record, Richard Whitley, that is correct.
Thank you. Okay. And then I think you've talked quite a bit about this, but I just want to make sure, big picture, that we're getting this question answered for the record. This fund does go on in perpetuity. A portion of the tobacco settlement dollars do go on in perpetuity. And what are, just big picture, what is the long-term sustainability of this funding? What's the outlook, particularly given the sweep that we did during the special session?
For the record, Richard Whitley, I would like to get the actual settlement agreement to you. I don't want to misspeak. It's my understanding that it does continue, but I want to verify that for you. I didn't actually use the term it goes on in perpetuity. What I was speaking to was the increase in revenues for this program over time, directly related to the purchase of tobacco products. But I would feel more, we get those funds from the Treasurer's Office. I would feel more comfortable to get that document to you with the settlement and not try to speak off of what I believe that it says.
Thank you. I appreciate that. And Madam Chair, that's all of my questions.
Thank you. And thank you for the discussion on this, this budget. Seeing no other questions, Director Whitley, we will move on to our next budget for today, which is 3203.
Great, thank you. For the record, Richard Whitley. Turning then to slide 15. The governor's recommended budget requests creating a new budget account within the director's office to consolidate the data analytics staff into one budget account. Currently, the data analytics operates in really a distributed model, which means that resources are spread in really a disparate way throughout the department, and this causes sometimes duplications of efforts, variability in the quality of data that is produced, and some of the programs have more robust analytic resources than others. So centralizing creates efficiencies and includes the ability to share enterprise level software and solutions. You can see on slide 16 that the E900 through E915 are the transfers of existing funding for data analytics. It remains the same. There's no additional request here. The funding sources are essentially transferred to this new budget account. And that concludes really my presentation on this, but I'd be happy to answer any questions.
Thank you, Director. I'm sure there's going to be a few questions on this budget.
Madam Chair, may I ask a couple questions, please?
You certainly can.
Thank you. It's Assemblywoman Carlton for the record, just so that our committee staff knows. So I just kind of want to get a real feel for what we're trying to do here, and how would this centralized data work with all the stakeholders that are going to be involved? You're going to get requests from state, federal, different agencies. We're putting this all together, which I think is a great idea. We have always said in this state, if you don't have the data, you can't measure it, you can't monitor it, you can't support it. We need to stop doing things on anecdote and really use the data, which I totally applaud. But I just want to understand how it will work with all the different stakeholders involved.
For the record, Richard Whitley, I actually think it will improve. I mean, coming from this office, much like the Office of Minority Health, I think the reach across our divisions to value data and to utilize it. I think one of the examples, hopefully you see it, but maybe it'll be more revealed in each of the divisions' presentations, those that have caseload. Kyra Morgan, our state biostatistician, really standardized and has working over the last biennium to really utilize the same standards of calculating caseload, and I feel very confident in it. That engagement, because there's a stakeholder group attached to, or multiple stakeholder groups attached to each caseload, I think it only makes it stronger. As you know, in government work, some people are community oriented and others can live in their category and do what's required and stop there. Fortunately for me, that's the minority of people that I have working in health and human services. The majority want to help. I think anchoring them all, utilizing data in the same way, coming from this office and valuing it, sends that message. I'm nothing but probably to a fault, engaging with community. It's with trying to find our common goals. Data again will help us with that. You can have a well-intended idea or even a resource for something, but if you're not utilizing the data to identify where the need is, you can even have evidence-based programs, but no evidence that we have a need for the program. So the data really does drive the programming at a community level. So I only see that improving and maybe raising the bar consistently across the department.
And Madam Chair, if I may follow up brief, and I'll try to make this brief because I know we have limited time today. How are those requests going to be prioritized? We have DHHS, we have the state, we have federal stakeholders, you have nonprofit stakeholders. How will those requests be prioritized?
I mean, for the record, Richard Whitley, so certainly requirements where funding is contingent upon reporting is, that's a must. So that's priority. That has to be achieved in order to keep the funding. Part of the benefit, I think, part of the benefit of having our biostatistician sort of hub all this activity has been that engagement. One thing that she does is if there is a data request, if it's a recurring one, she builds a dashboard so that she can populate that same analytics routinely as the data becomes available. So that which has been great because other people may have had that question, but they never quite saw the data depicting it. And so that I think that's a continuous process that she's implemented. The other is where we find disparate use of services. Second to funding is it may appear on the surface that we're providing a service, but unless you dig in the data and identify, prostate cancer is a good example. Like we get it reported, but African American men get diagnosed with later stage cancer because they're not screened earlier. So who are they? Where are they? That certainly would rise to the top because there's something we could do about it. The screening is available. We just need to inform. So there would be multiple priorities, and I think that should drive us. That we discovered something, we know it. Now, what are we going to do about it? I mean, the challenge may be that during the biennium, when if you all support this, that we come back before you and say, look at the data. We believe we need to do something about this, and it's in this area, and it would cost this amount. That might be an outcome of it, but it certainly would help us leverage our existing resources to make sure that across the board we're serving people equitably with a sense of urgency and priority. You mentioned food security and what nonprofits are seeing. I think that's a good example as well. I think we report to the feds to get the funding categorically, but in a family where they may be eligible for WIC and SNAP and school lunch programs, we don't do a good job always of providing that complete picture to say, here's what a Nevada family needs. We can do the categorical reporting. So I see a benefit in that as well to drive our programs. And it may not cost any more money. It just may be working more wisely. So it may lead to me putting forward a future integration of something because the data showed us that these service programs need to be working in a combined effort. So I think the top priority, definitely funding requirements and reporting out so we don't put them at risk. And then I do think that the driving the program implementation, I'm gonna hold folks accountable to, if the data informs us, what are we doing about it?
And thank you very much, Director Whitley. And Madam Chair, just a closing comment. I mean, I think it's very telling that there was a pilot analysis, and I was very happy to see this in our notes conducted. And we'd always known this in SNAP, but now we actually have some data that, folks with SNAP are disproportionately overweight and obese and have a prevalence to chronic disease and diabetes. And that's why a lot of the food pantries focus on very, very healthy food, because people try to stretch that dollar. So now we actually have the data and can start working towards a healthier population that needs to use SNAP, that are in that unfortunate position right now. So thank you for getting that. And I really appreciate where we'll be able to take this data in the future. Thank you very much, Madam Chair.
Thank you, Assemblywoman Carlton. Senator Keffer, you have a question?
I do. Thank you, Madam Chair. I appreciate it. Director, I really like this idea. I think this is a proposal that makes an awful lot of sense, and bringing all of our people who do this into one shared space. It's going to offer opportunities for them to collaborate and work together and share ideas in new ways. And I think you're likely to get a lot of really interesting work products coming back to you. I have of the 27 positions though, and all of the funding, none of it is coming out of healthcare financing and policy. It's all coming from your other agencies. The HCFAP has obviously the largest contact with people in the state, and they have tons of data. Why is the HCFAP sort of carved out of this?
For the record, Richard Whitley, I wouldn't say that they're carved out of it. I think that, when we do organizational changes, I'm confident when we demonstrated a change, but we're maturing our state Medicaid program at the same time. There will be work collaboratively between the two programs, but it's not a change. I mean, maybe this is incremental policy making that I certainly don't want to actually indicate like this box is now established and not, we won't do anything more. There's certainly things that will come along, but at the same time, I don't want to scoop up, go through a budget and just identify, well, you have a touch point to data. So we did this very thoughtfully in terms of engagement with the program, much to Assemblywoman Carlton's point about prioritizing. There are some programs that are just really data focused. And so how to work those together. We certainly have been working Medicaid with the biostatistician, and again, the authority from my office, I think that is helpful. I mean, not to just bear our underbelly of an agency, but getting the state biostatistician just to get access to databases in our own department in order to do matching was originally a challenge. And so that's, there may be future opportunities, I think, to look even at looking at federal match for enhancement of data. But in all sincerity, this is what I'm comfortable with not taking on more than we could accomplish at this time.
Okay, I appreciate that. That's fair. And then the other question that I have is related to how you're going to be able to sort of accurately fund map this work to ensure that time is billed to the correct funding sources. It's only 25% general funded, and I know a lot of these positions probably have a lot of restrictions on what they can do based on their funding source. Feel confident that bringing them all into one place is going to allow you to continue to monitor that and ensure that we're in compliance with those restrictions.
Yes, again, for the record, Richard Whitley, we are required to do that, and so it's tied to actually the employee's timesheet, and we've had programs before in the past that needed to make improvements in that area. That is one area where the actual time and effort is monitored and will continue to be when it's in a single budget. That won't change.
Appreciate that. Thank you, Director Whitley. Thank you, Madam Chair.
Thank you. And our last person for questions will be Dr. Titus.
Thank you, Madam Chair, and thank you, Director. I too think this is a great idea because I've always had questions about what the data shows and being able to tie that data to outcomes. So we have a service. Has it really done what we wanted to do, what we wanted to spend this money on? So hopefully we'll be able to use this department now to probably collect some of this really important outcome data because we know and we've identified that rarely does a person need just one service. They need, if they're on Medicaid, they may need TANF, they may need some other services. So hopefully we'll be able to tie some of that together. My question for you is, if we're getting all this data, specifically maybe people who may sign up for Medicaid, who might sign up for TANF, will we be able to identify perhaps, are they underemployed? Will we have some of that information? Because one of my concerns and one of the questions have been, we have many companies here in Nevada that have gotten some tax rebates, have gotten some assistance from our state. But I have people reaching out to me concerns that those particular employees or employers have a lot of employees that use Medicaid. And so will we be able to collect that kind of information? Because I think it's not just about outcomes, it's about who are we as a state providing Medicaid to, and are they, as we use the term, underemployed now? And did indeed that company get some big tax rebates or cuts or assistance from the state of Nevada? And now we are supporting them when they're perhaps, I have no problem with somebody making profits. I'm a capitalist. However, is at the end of the day, the state of Nevada, the ones that are paying for their employees to be on Medicaid. Will we be able to see that kind of data?
For the record, Richard Whitley, absolutely. In fact, you can see it now on our website. Kyra Morgan, the state biostatistician, does do a report on Medicaid enrollment by employers. And I'll just give you an example. The state of Nevada is in the top 10. My department ranks the highest among people. What am I doing about it? Well, one thing that we've taken on internally is where are those? They're primarily single moms who qualify for Medicaid. But how do we create career paths? We know what people need to make in order to get out of poverty. And so we're doing strategic, because if I can't model the behavior, what business do I have of asking Walmart or an organization, Walmart being the #1 employer of people on Medicaid. But if I can't show a pipeline of how someone can get out of poverty by advancing in state service, I've got work to do internally. So we are doing that, and we are reaching out to our welfare eligibility workers to be able to really change a mindset that, and working in partnership with Workforce Connections, particularly in Las Vegas, that helping people to just secure a job. You can do the math. If they're a family of 3 or 4 and the income is static, what their level of poverty is, and if there's no opportunity for promotion and making an increased salary, they're locked. And so how do we help folks? Maybe Walmart is a launching pad to another job, but to work more strategically that way, the data will help us with that tremendously. If we see that people have underlying, as Assemblywoman Carlton mentioned, the matching of Medicaid and SNAP data, and identifying a high prevalence of diabetes among SNAP recipients who are also on Medicaid. We can also do that matching with data to just be able to not identify at a personal level, but identify programmatically what sort of assistance people need to actually move the dial. So I'm most excited about this area in terms of looking at the underlying poverty that maybe is holding people back. Many people say poverty is a determinant of health as well. And so helping people to get out of poverty, I think, is a part of what we need to do. When you mentioned like Dieter, up until, it was nice having Elise from our department go over as the director, because we now are sharing data and we are able to get more information to be able to better understand, are we serving these individuals, and how can we work collaboratively to help them move out of poverty. And so I'm most excited about this area because we could change people's lives really by maybe not new funding, but really just working together more wisely.
Thank you for that, sir. And if I might, just a comment, Madam Chair, I think it brings us to this next budget item, and we'll get there obviously when we get there, but I think recognizing who maybe doesn't need Medicaid and maybe some moving that over to the Silver State Exchange and some of those issues, I think we can use this data to make sure we can identify what the solutions are. And so I think that's just, it's all well and good if we have all this information, but if we don't have a solution, it's just there, right? So it sits on a piece of paper. So thank you for what you're doing, and thank you for the question, Madam Chair.
Thank you, Assemblywoman Titus. So, members, any other questions before we move on to our last budget account for today's meeting? All right, seeing none, then we will move on to budget account 3204, the Consumer Health Assistance. If you would go ahead with that presentation, Director Whitley.
Great. Thank you. Again, for the record, Richard Whitley. So the final budget account 3204 is the Office of Consumer Health Assistance. And on slide 17, you can see that this budget account assists Nevada consumers to understand and navigate really the complex healthcare system. It provides, and they do that with not only the payers, but with the providers, and also with assisting with access to services. They respond and investigate complaints related to healthcare plans and policies, and they assist consumers with billing disputes, particularly between the patient and the hospital. Turning to slide 18, the Office of Consumer Assistance is primarily funded based on time tracking, and the appropriate charges are made to the appropriate funding sources. And as discussed previously in the presentation, E900 transfers the Office of Minority Health to the Director's Office, allowing this account then to be available to be transferred. E903 and E904 request the transfer of the Office of Consumer Health Assistance, including 211 program, to the Division of Aging and Disability Services. And I'd be happy to answer any questions about this move request.
Thank you. Members, does anyone have a question on this budget account?
Yes, Madam Chair, if I may.
Go ahead, Assemblywoman Carlton.
Thank you so much. And I had an overarching question earlier to get that on the record so everybody was comfortable with it. With the other moving pieces of this, I'm not sure if this is the appropriate spot to ask this question, but under the details that I have and the conversations that we've had, with this, and everyone knows how interested I am in the Patient Protection Commission, so it's not a secret. I'm just wondering about how that will, and if it's not the appropriate spot, I understand, but I believe that's going to be located here also. And Director Whitley, you and I have talked about this one a couple of times, and I think you know how important this is, how high level this is. Going back to, if we don't understand where healthcare really is in this state, it will be hard to decide where we need to go in the future with it. So if this is the appropriate spot to kind of go over that thought process on the Patient Protection Commission, but if not, if there's another time, I'll be happy to hold my question until then.
For the record, Richard Whitley, it is most appropriate for aging and disability, and I'll participate in the discussion with Dina Schmidt on that. That's where it's not actually in this budget, but you know, I can talk about whatever you want me to talk about, but it really would be most appropriate. That's the action. But I think what you're getting at is the action that I'm taking from this budget account builds a framework on which it's proposed that Patient Protection Commission resides. And so if I'm understanding, then your line of questioning.
And thank you, Director. And if it's at another time it's more appropriate, that's perfectly fine. I just wanted to make sure I don't want it to get lost. I think it's very important that the state keep having these high-level conversations about what the status of healthcare is in this state. So, and addressing issues that impact patients, yes.
If I may, I think what we're trying to do, maybe it's helpful in that I think the changes in this budget account in the recommendation to move these components to aging and disability provide really the framework, which I think the discussion about the appropriateness of the Patient Protection Commission and how it relates would be a natural next conversation. But I'm careful about making a change in something because there's always unintended consequences. Rarely do we have opportunity, even with a grant, we get a new program. Where should it reside? Well, we haven't had it before. I'm going to make my best assessment, and we're going to work together to try to implement it. During the past year, during the pandemic, we have had to work these programs, not patient protection, but these categorical programs together to respond to consumers. And as most people know, the healthcare system is complex, from payer to provider to the consumer experience. Sometimes things do go wrong. Sometimes they don't, and it's a matter of helping people understand. Doesn't matter if you're the consumer and you have the experience. So we have actually been integrated just to be responsive, to the pandemic, primarily with the Nevadans who are elderly, frail, who we've asked to stay home. How do we help them navigate their healthcare system? And so one of the things that we've identified are some efficiencies, and the other is just responding to consumers so they don't have to get in multiple lines to be helped. We do it with information. That's 211. We do it with information. If the information, sometimes there's criticism from the counties that 211 isn't as current as it needs to be. Well, tying it to the consumer experience in a more direct way, I think will only enhance it, because information is the first. If we can solve a problem early with information by informing people of what their rights are, what the process is for appeal, all of those things with information, we can maybe prevent them from having a bad outcome or an experience. The second thing that we do on that continuum, though, is help clients navigate. And we do that with the Office of Consumer Health. How to move about in the system and understand like your health policy, what's covered, what's not covered, if you're underinsured, what that means for you. So helping consumers navigate the system, again, on a continuum from information to navigation. The third thing that we saw is that sometimes we do have to intervene with adult protective services. The goal would be to prevent the intervention whenever possible. How to do that, though, is to work across a continuum. And these programs, although they all exist, they exist in a scattered way. And so that's really the intention here, is to integrate across a continuum and in more real time, be able to upload information into 211 if we're seeing a particular misunderstanding about a service, that it's tied directly to the consumer experience. One of the things that happened when we expanded Medicaid, we didn't hit a reset organizationally on how we function. And what we're seeing is this health literacy piece, consumers understanding their health status and how to navigate the healthcare system is only becoming more central to everything. Even on the data side, in terms of their own health, it's how to help them navigate the system, inform them, navigate, and then intervene when possible. So again, I do not believe that this is a risky venture in terms of the programs in this budget that I'm requesting to really hub within aging and disability services to serve consumers in a continuum from information to navigation to intervention. I think the separate conversation is the one about patient protection and what role policy plays, related to that overall consumer experience.
Thank you, Madam Chair. Thank you, Madam Chair. Mr. Whitley is very passionate about these things, so I'm always careful of what questions I ask him. Thank you very much, Mr. Director Whitley, for the answers. And back to you, Madam Chair.
Thank you, Assemblywoman and Director Whitley. We do love your passion for this subject matter. We have Assemblywoman Titus and then Senator Keycapper.
Thank you, Madam Chair. And again, Director Whitley, thank you. Under the details under this particular budget item, and the rationale for it is that it will streamline kind of access to appropriate level of services. And we know that the 211 program is intended to have more information, and really the term that's been floated out there for many years is no wrong door, so that when somebody picks up that 211 or dials 211, folks will get directed to the appropriate services. So again, that no wrong door theory. One of the concerns I have is though it's under the justifications that it's going to streamline access to appropriate level of services. Access is different than referral. And so one of my concerns is where's this actually going as far as access to care? Because we throw terms around a lot and really will, and that's where this data is going to come in. I'm going to want to see the data that truly people didn't just dial 211 and say, well, yeah, that's this department. We'll send you to that. We'll refer you to that. Did they actually get the services that person needed at that time? So hopefully by kind of consolidating all of this, we'll be able to see that outcome data to make sure that indeed it did streamline access. So how do you think it's going to actually improve access?
For the record, Richard Willie, I mean, I would encourage anyone to call 211. I've called it before just because I'm appropriately cynical when someone tells me something works. Like, does everyone have that same experience? And so I've called it before to ask, refer me for a service. One feature that it does have, it has a callback to see if you actually made your appointment. So I'd be happy to share with you the data from 211. I think it has a lot of features. It isn't just a referral line to say, okay, well, I move, inbox, outbox, I move this person along. The key nuance to it, though, I think where we can do better is the closer it is to where consumers have experience and that we are seeing, because again, I think if you just look at, hopefully I'm not being too shrill about this. I am passionate, but I'm trying to moderate and not go overboard. I think that you have to look at information on a continuum, and that this is a service component. I mean, again, as I said with tobacco, knowledge doesn't change behavior. So sometimes people have to have that follow-up, or because what if the service is available, but transportation isn't available? I know for food security that we provide SNAP EBT cards in Las Vegas, but there are food deserts in Las Vegas. So that's great. They have a card, but if there's no grocery store, or it's only a high-priced liquor store with a few groceries in it that takes EBT, that's not helpful to people. So the intention would be to be nuanced in terms of what was the consumer experience, and that is collected with 211 in terms of follow-up. And I'd be happy to, I really would do the program more justice to provide the information to you.
Great follow-up, Madam Chair.
Go ahead, Senator.
There's different responses in the 211 depending on your location, unfortunately, and it's not updated as frequently as I think it should be. And when we dial 211, if we're located in rural Nevada out in the hinterland versus what happens if you're down in medically deprived and urban center, what their experience of 211 is. And so it'd be good to see some of those, I think really focusing on updating what 211 means where. And I think because there's different interpretations of that, but with that, thank you for that. I'd love to see some of the outcomes on that, and good to hear that you do have a follow-up on calling and making sure that they got that appropriate appointment, because again, as you mentioned, we can do all we want, but it doesn't always change behavior, nor if they don't have a car to get there or some way, none of this works together. It's all just, as you had mentioned the word silos before, I'm afraid it continues to be just in some silo somewhere. So thank you for all of that. And thank you, Madam Chair, for the question.
Thank you, Assemblywoman Titus. And those questions that you were referring to may be better addressed when we hear from ADSD as we move forward in our subcommittee hearings. So I will thank you for that. And I will move on to our last question for this budget item, and that will be Senator Keycapper.
Hey, Madam Chair, I appreciate the indulgence. I know I've been on the mic a lot today. And, you know, this might be a question that if the director wants to punt to the ADSD presentation, that would be fine. But I think I understand, Director, what you're trying to do, and I think it makes sense. I'm just not convinced that ADSD is the right house to put this in. This is an agency that's focused on serving two specific populations, really, that have been long underserved and ignored. And I worry about diluting their mission with programs that expand outside of those population bases. I think Chairwoman Carlton mentioned, you know, the Patient Protection Commission. This is a broad sort of overarching commission that has broad duties. 211 is the same. Maybe, you know, the health care navigators might fit into that category as well. And I just wonder if ADSD is the right place for it. Is there a reason that this is the agency you chose versus another one? And why should I not be worried about diluting that mission?
For the record, Richard Whitley, I think it's because they operate in this space, and yes, they have probably the most focus with the populations they serve, people living with disabilities and people who are elderly. But they also expanded adult protective services. And we, you know, we don't invest a lot of money in general fund anyway, in supporting some of the population-based or public health approaches to service. And so sometimes you'll see in our department, we're doing the best we can with just coordinating services. And so that's the effort here, really, is they're the best agency because they already have the consumer as their centerpiece. And, you know, that building off that, they did expand adult protective services. I think we have to do better in that area, and I do believe that they're the best agency for that. Their title may not reflect it, just like I said previously, that, you know, the term welfare is a stigma for some, particularly elderly folks, to access food security. So their title, but I mean, the service is far much greater than the title of the agency, and they do serve more than those two populations, like I said, with the expansion of adult protective services. It's a hub. You know, if it doesn't belong there, the work itself, it's the only place that I have in this department that really is central to that functional role. So that's the logic on it, and they've demonstrated it, taking that on during this past year with efforts with consumers and their need for information, navigation, and frankly intervention. I think the role they play with like when somebody needs I don't know, like when we've seen a lot of challenges in facilities like hospitals and people waiting for discharge, and with the capacity increasing and the need for swift discharge, they've played a key role in assessing and knowing where the needs, you know, what the consumer needs are and getting them placed. I think their role has expanded beyond the title of their agency, and I do believe this is the appropriate placement for the consumer services that we have.
I appreciate the response, and I'll look forward to talking more with the agency when we have them in front of us. Thank you, Madam Chair. Thank you, Director.
Thank you, Senator Keffer. And thank you to Director Whitley and your staff for the presentation today, and the members on this subcommittee for your very important questions as we went through each budget item. That will bring us to the last item on our agenda today, and that is public comment. So if there's anyone out there that's been going along with us online for today's hearings and you have questions, I'd like to let you know you can register online to speak to the committee by phone, or you can submit your questions in writing. You can go to our legislative website on Nellis to submit your questions. And I will ask our BPS staff if we have anyone currently waiting for public comment.
Yes, we do have one caller. If you're ready, I will ask them to unmute and get started.
Thank you.
Caller with the last three digits, 398. Please slowly state and spell your name for the record. You have 2 minutes and may begin.
My name is Nancy Bowen, Nancybowen. Good morning, Chair Monroe Moreno, the members of the subcommittee. I am Nancy Bowen, CEO of the Nevada Primary Care Association. We represent the state's 8 community health centers, also known as federally qualified health centers, or SQHCs. Our members provide integrated primary, behavioral, and dental health care, along with family planning services to more than 107,000 Nevadans in more than 40 clinic sites statewide. SQHCs were created to serve underserved populations and geographies. In 2019, 88% of Nevada's SQHC patients had incomes below 200% of the federal poverty guidelines, 70% were racial or ethnic minorities, and 24% were best served in a language other than English. In some rural Nevada communities, SQHCs provide the only access to healthcare for many miles. A full fifth of our patients come from rural Nevada counties. SQHCs are uniquely provisioned to provide care to patients left behind by the traditional healthcare delivery system. They receive cost-based Medicaid reimbursement and federal grants to serve uninsured patients. They also offer a sliding fee discount scale and do not turn away patients due to inability to pay. Our health centers serve more than 42,000 Medicaid patients and nearly 31,000 uninsured patients in 2019. They also access discount prescription drugs through the federal 340B program and pass those savings on to patients. SQHCs are uniquely organized to serve your communities. Per federal guidelines and in the community health center tradition, stretching back to the civil rights era, SQHCs are governed by a board consisting of a majority of patient directors who come from the community being served. Many of our health centers are also patient-centered medical homes, meaning they have been recognized by the National Center for Quality Assurance for their skills in integrated care, patient navigation, and formal quality improvement processes. This is the third session that the Department of Health and Human Services has proposed an investment into SQHCs in the Grants Management Unit budget. That 2 governors from different parties have included these proposals in their budget speaks to the bipartisan support that SQHCs enjoy in Nevada and across the country. I'd like to note that the Nevada Primary Care Association has worked closely with the GMU to ensure that this investment increases access to health center services in the state's most underserved communities. We ask that you continue to value community health centers by approving and supporting the federally qualified health center incubator project in budget 3195. Thank you for your time and allowing me to comment on this important matter.
Thank you so much for your comments today, Ms. Bowman. Do we have anyone else on the line for public comment?
Chair, the line is opening and working, but there are no more callers at this time.
Thank you so much. Members, with that, that brings us to the end of our agenda for today. I'd like to again thank our presenters and our staff, all the work that they are doing, and with all the IT issues at the onset of this meeting, thank you for getting us all on. Our next joint meeting will be on February 10th, and it will be chaired by Senator Ratty, and I look forward to seeing you all then. This meeting today is adjourned.
Thank you, Madam